Okay, sorry for the wait. I think let's start. It's about patellofemoral joint problems, and I've chatted to Brad, and we decided to have a couple of cases, discuss the cases. If there's any questions you guys need to ask, or you can just chip in. And I've asked the 4 or 5 guys that are writing to have a case, a small case, and then we can maybe distribute that case to each other, and I'll ask some questions in between. So let's start. Maybe Brad, if you share your screen, and then I'll give a talk just to wrap it up and kind of bring things together, hopefully at the end. Not long, half an hour for me, and then hopefully another half or maybe a bit longer for the cases.
Okay, cool. Here goes. So if I can do this.
Perfect. I
Okay,
can
cool.
see that. So maybe who's in is Salma. Salma, are you around? Okay.
Yes, I am.
You want to take that
Are you
case?
saying Selma or Zama?
Salma. Dr. Amas.
I'm in.
Okay, cool. Let's do it.
Okay. 22-year-old, traumatic patellar dislocation, managed consecutively for a year, now ongoing pain with recurrent dislocations. So presented is X-ray images, sunrise view of the patella left and the MRI view, T2 weighted, water is white. I'll start with the X-ray. Just looking at the patella itself, it looks like patella bipartite, most likely, because I can see that I think it's the medial aspect, wasn't the lateral aspect of the patella, that you can see that congenital, not deformity as such, but like partition of the patella. The patella is riding more, laterally. I think that's the lateral edge of the femoral condyle, and underlyingly mild sclerosis that I can appreciate. And I think there is, I'm not quite sure if that just swelling, soft tissue swelling under the patella or anything, but you can see there's a grayness just inferior to the patella. And then just to comment on the femoral condyle, so the trochlea, seems not quite deep. So I think for this case, patient most likely has a dysplasia with an associated patella bipartite, and potentially the reason for the recurrent dislocations. And then on the MRI images, I can appreciate fluid within the joint, and once again, that flat groove of the femoral condyle or trochlea, that is indicative of most likely a dysplasia of this patient.
Okay, perfect. And Brad, do you want me to ask a couple of questions, or do you have you got a couple of questions prepared?
Yeah, prepared a few things. So yeah, I just thought it was an interesting case, and I put these two up. It is the same patient. It's obviously just a slightly different cut there at the MRI. But what I found interesting was,
sorry, why do you think that the patella on the X-ray is so well formed, and then on the MRI scan it's not?
I don't know. I thought it's a different level of the cut that we're looking at.
Yeah, exactly. So that's the problem with the sunrise views or with the tangential view of the knee. So if that X-ray is taken with the knee more flexed, then you'll actually see a deeper portion, a more distal portion of the notch, which, but you know, it's basically a lot deeper than the initial more proximal part of the trochlea. And it's actually the proximal part of the trochlea that really determines whether the patella will sublux or not. So the further you go distal, the less the patella will sublux or dislocate, because it would automatically becomes deeper there. And that's the problem with just having an X-ray. What is a better X-ray to look at to be able to judge the dysplasia, Salma?
The lateral.
It's not a trick question.
Yeah. I can't think at the moment, but I know there is another view. Can't remember it at the moment.
Yeah, it's the lateral view. And we'll get to it hopefully either in this case or later on. And I'll show you a few things on how you can judge. It's not good to actually prepare surgically, but just to kind of have a few red flags that you can look at on the lateral X-ray to determine if there is or potentially unmask some patella, some trochlear dysplasia. But sorry, Brad, you go on.
Yeah, no, that's great. So I just thought it was interesting. I don't know if you guys can see my mouse, but obviously it's a different cut, and the sulcus angle here on the X-ray, it doesn't look too bad. I would have thought that's probably around about 140. But if you look at on the MRI with the cartilage, and obviously at that cut, you can see it's basically convex. So taking into account that cartilage and how that will affect your sulcus angle and how your patella is going to engage, I just thought that was quite interesting here. And then I just wanted to show you, so that's obviously the sulcus sign. There is some normal range, but most seem to agree that over 140 degrees, you're starting getting into an abnormal area. And we classified with de Jeu's classification. So he puts it here at 145. So shallow trochlea progresses to a flat one. And you can see the changes as well with the lateral. And then you've got that convex trochlea. And lastly, the one with the cliff. You can see the cliff and how they fall down that. So those are your high grade dysplasias. And then just what are the options? It seems still quite controversial. Not many guys that are doing this, but the different forms of trochleoplasty, a lateral facet elevation here. I think this was one of the first ones that was described. And then probably the most common and being done sort of arthroscopically now with burrs and so on is a sulcus groove deepening trochleoplasty, where they elevate the whole trochlea. And there's one picture here that shows it. So I think this is the Barreter technique, they call it. So, quite incredibly, just lifting off all of that cartilage, getting a burr underneath there, and then creating a shallower groove in the subcondylar bone down there, and then splitting the cartilage to create a groove and tying it down with sutures and anchors. And there you can see they recreated a nice trochlea. So it's quite impressive surgery. Yeah, that's what I've got.
Thank you very much. So let's quickly chat about this while you've got it up. So let's go back to your first slide.
Yep.
And what you see on the MRI scan. So actually, if you really, firstly, Brad, what are the risk factors for traumatic dislocations? Sorry, for recurrent dislocations.
So trochlear dysplasia would be one of them.
Okay. Probably
yeah.
Trochlear dysplasia is probably one of the most, the highest, has got the highest risk of all the risk factors, probably the highest risk of recurrent dislocation, yeah.
Then hyperlaxity comes to mind as well. They can become recurrent or sort of atraumatic.
Yeah.
And then all of your malalignment things as well. So your femoral anteversion.
See, it's structured a little bit better. So let's make it a model answer. So
I suppose we said, so that I would say hyperlaxity, I want to say malalignment issues, and developmental problems. So like then it's your dysplasias in there. Other things, I mean,
Yeah,
traumatic,
so I
obviously,
mean,
body.
we would say probably patient specific and specific to the alignment in the leg, and then specific anatomy, um, anatomic variances within the knee. So yeah, but when we look at, so trochleoblast dysplasia is probably one of the biggest driving factors for subluxation or recurrency. But in this case here, 22-year-old, that's young. That's an issue with recurrency, and that this patella is very flat. And there's various other things like rotational malalignment or patella position. What do you know about the patella position? What makes the patella dislocate more?
So I think that's, are you referring to the TTTG? And that if there's more than a TTTG of more than 20 millimeters, would then be an indication for surgical correction of that. So
okay, and explain what the TTTG is.
Yeah, so it's taken on your axial cuts, looking at the center of your trochlea, and then further down at the center of the tibial tubercle, and in superimposing those two images, if there is lateral displacement of more than 20 millimeters, so from your trochlea to your tibial tubercle, then that's effectively the lateral pull, and that can cause patellar instability. And that can be corrected by an osteotomy, anteriorization and distalization procedures. The Fulkerson, I think it is the most common one performed to correct that.
Okay. Yeah. Okay. So basically, the patella moves lateral due to various things, but one of the most common things is that the tibial tubercle is lateralized. So the attachment point of the patellar tendon is lateralized, and that's why the patella is also more lateral. And you can imagine this patella, for example, I would be worried that the tibial tubercle is attached more lateral than normal. And like you say, we can measure that distance between the tubercle and the groove of the trochlea and the tubercle on a various axial slices. The distance, there's a thumbsuck figure of 20 millimeters that is often seen as an indication for surgery, but it just kind of tells us or helps us to describe that lateralization. And the other thing is, the further superior, the further proximal the patella sits, the higher it is, the longer it takes the patella to actually get into the groove. And so it has more time to sublux or dislocate. And so those two things are very important when we look at the recurrence rate. Okay, cool. Then when you go one slide to the next. So this is a very complicated way to look at things. And this is what I'm talking about on the lateral. You can actually see the schematic drawing of the lateral X-ray. And these are the things that you can look for on a lateral X-ray. And I think if you remember this in the exam, you've already the examiner talking about this. The examiners have already given you a high mark, and you're gunning for a very top score now. But I think if you grade the patellar dysplasia, the trochlear dysplasia, just use the Bristol classification, which is very simple. It classifies it into a normal, a shallow, a flat, or a convex trochlea. And that has got very good better inter and intra observer reliability than this one here. And it tells you more or less also when the indication for surgery is given. So as soon as the trochlea is convex, it's very difficult for the patella to actually find its way into the groove. once it's flat, it can still be kind of kept in the middle with other procedures in the middle of the knee. But once it's convex, it's very difficult to, even if the patella is medialized, to be able to be guided into the trochlear, because it's basically it doesn't have a landing strip. So with these, the only thing that you have to remember here are certain red flags when you look on the lateral side, and the one is the crossing sign. So the main thing is you'll see here on the lateral X-ray, there's two lines. One line is for the deeper one is that's where the Blumensaatz line, basically posteriorly, the Blumensaatz line becomes the floor of the trochlear, and then the more distal line, that's obviously the condyles. And if those condyles cross over anterior to the anterior cortex of the long axis of the femur, then that means that the trochlear is very shallow, because that means that the crossing sign is made by the two condyles. And it's not just shallow, but it's also quite short. So that's this crossing sign. The other thing is the spur, and the spur just indicates that there's a little bump as the patella moves distal in flexion. It hits this bump, and if this bump is big enough, then it can dislocate and over the bump and out. So that spur is basically that bump. And then you have here the cliff sign, that's the double contour. So if you see a double contour, crossing sign, or spur, then you know, oh, there's something going on, and you have to investigate further. And let's go one more. So this elevation, so if you consider, let's go back one more. So so you see there's actually no trochlear here that ever has a lower lateral side that needs to be elevated. So initially, people thought that by elevating the lateral trochlear, we can kind of keep the patella medial, but actually all it does is just increases the contact forces, and it doesn't actually keep the patella medial. It just creates pain and arthritis, because you can see type C and type D, the lateral part of the trochlear is actually elevated. So that doesn't make sense. So the only two other things that we can do, and now go back again, is to deepen the trochlear. So if the trochlear is convex, then we can do a deepening procedure, or a lateral, you can take a wedge out on the lateral to actually decrease it, to decrease the a spur, and create a nice smooth entrance into the trochlear for the patella. So either you deepen the trochlear with the Breiter plasty, so you can just go one more further, where they basically lift the cartilage up, make the trochlear deep, and put it back on. Or you can just do the lateral part of the trochlear, and you can take away the spur underneath the cartilage and put it back. Okay, cool. Let's go to the next case. Thank you very much. That was a nice nice case, Brad. Let's see, maybe who else? Sama, do you have a case?
Yeah, I do.
Perfect. Choose one of the senior guys to ask.
It's not as intense as the last one, but anyone can volunteer whilst I share my screen. Otherwise, I'll pick someone.
No, it doesn't work, Sama. Yeah, I'm gonna just say, how about who's
You
it?
see my screen. Let's just
Fidelis.
choose. I think
with the
Fidelis,
flowers,
fine.
and I think with the flowers and everything, I think it must be Fidelis. I think he's the right person for that.
Okay. I've actually never shared my screen before. Hold on.
Although there are some thorns on that flower bush, Fidelis.
Yeah, not a good sign.
Is
Typically,
this working? Can you see the case example?
Perfect.
Okay. So a 12-year-old female arrives to the rooms with knee pain and instability and trauma. She said she sees daily at school and she's called Miss Knock Knock Knees. And there you go. Yeah.
Okay. Yeah. Apologies. There might be some banging noise in the background, some construction happening next door. Yeah. So the two images, anterior view and the posterior view of a young girl up to the mid thigh. Obvious gross abnormality is a severe genu valgus of the left knee, with slightly looks like an slightly external rotated foot. Left knee looks like it's slightly lower than, but I think it's just an apparent leg length discrepancy. If you look at the creases at on the post from the back view, it looks like the left lower limb might be slightly short. To the far right is lower limb views. What's striking is really make out what the size is, but I mean, clinically correlating with what's on the image, I would say she's got a lateral mechanical axis deviation with genu valgus on the, looks like it's on the right, but clinically looks like it's on the left. And then the patella is facing like it's facing outwards as well, which will be in keeping with probably external rotation profile of the lower limb.
Yeah, so Manetsi, sorry, these are just Google images. I know the clinical picture looks like it doesn't correlate with the X-ray, but you get the gist of it.
Yeah.
I'll take it to the next slide. So the question posed, what three alignment features make up miserable malalignments, which predisposes her to patella instability? Because she initially came into your rooms complaining of pain and instability.
Okay. So in miserable malalignment syndrome, you've got excessive femoral anteversion. Then you also have genu valgus, and then you have external rotation of the tibia.
Yeah. So genu valgus, femoral anteversion, and external tibial torsion. Yeah, that's what I manifested. Prof.
Okay, cool. Well, that's a nice kind of trigger for some discussion. Firstly, how do you classify patellar dislocations?
So they can be acute versus chronic or recurrent patellar dislocations. And then I think directional as well. More commonly, it's mostly lateral patellar dislocations.
Is that how you classify you? Like, is it the Munetsi classification, or is this like a classification that you read somewhere?
I don't have like a named classification, Prof, but
there's a name there. Yeah. There's a kind of a way to look at it in a pediatric patella. So you kind of, when you look at patella instability, there's two types, two classification kind of groups in your head. The one is for pediatric patella dislocations, and the other one is more like a directional classification. And so you can also classify dislocations in kids directionally, but specifically for kids, there's a classification that talks about, and it's the Gaustin classification. You don't have to know the name, but it's syndromic, obligatory, fixed lateral, or traumatic. And so that allows you to kind of go beyond just directional into more like, why is this actually happening? With obligatory, that means that the patella dislocates every episode of knee flexion. and it reduces an extension. And then, you know, traumatic is obviously something that it's self-explanatory. And fixed lateral means the patella just stays on the lateral side in flexion and extension. So in often these cases that Zama presented now, that's actually a case where often the patella will actually be laterally dislocated. And for that, there's a specific way to treat these. So this is not necessarily a traumatic dislocation. It's also rarely a habitual dislocation and is not really a congenital dislocation. So this is most likely going to be a fixed lateral dislocation here in this case. But let me show you, Zama, just because I want to, let me ask you first, what would you do here? Obviously, this patient is coming to us now. She's had multiple dislocations of the patella. It doesn't really get better, and she's really struggling. It's affecting how she even walks stairs. It's the extension power strength is massively reduced. Can't do sports. It's really struggling, and it's got some patellofemoral pain. But how would you address this?
Okay, so in this case, so obviously there is a bony problem, and I assume there's also like a soft tissue problem as well. So bony problem, I mean there is a malalignment with deformities which cause an increase in the Q angle. So in terms of principles of management here will be we have to correct the bony deformities and then augment that with possibly soft tissue procedures. So in terms of the bony deformities, then map my ABCs using measurements on the X-rays to see where the deformity is, and then plan corrections in terms of depending on where the deformity is, using possibly the rotational osteotomies, and then as well as addressing as well if any other abnormalities, let's say in terms of your anatomical position of your tibial tuberosity. If according to your measurements, the patient has got an abnormally high or an patella, then you might have to do like mentioned earlier, distalization or medialization osteotomy of your tubercle. And then after you have corrected the bony abnormalities, then you can decide to augment that with a soft tissue reconstruction, which might involve augmentation of your MPFL, or in this case, where the patella is chronically dislocated, they might have a contracted lateral soft tissues. Then you might have also have to consider doing lateral releases as well.
Okay, perfect. So there's quite a lot of things that you mentioned now, and obviously we're like almost moving from the back to the front here when it goes to severity or complexity. So these are probably the most difficult ways of patellofemoral problems that we're just looking at now, and probably also quite rare to be treated. So the one trochlear dysplasia and the other one, this kind of malalignment. The issue is this, is if you treat this just with soft tissue surgery, it will it will try to pull the patella medial, but the patella will still want to go and track lateral. And over time, all you're doing is you're over constraining the patellofemoral joint. So the main thing is really to correct the alignment of the patella. So let's talk about the bony procedures here. And I think in this severe case, it's obvious and makes sense to change the alignment before we do anything with the patella. So what normally is done is to do a varus producing distal femoral osteotomy. Now, how these deformities usually present is with valgus and with a high femoral neck anteversion, and then an external rotated tibia. So the tibial tubercle is lateralized. The femoral neck is internally rotated. And then the distal femur, or depending on where in the femur it is, there's a valgus in it. And the way to treat this is a distal femoral osteotomy that derotates the femur and it creates varus. I'll show you a case quickly because I actually have a surgical video in it. I will just very quickly fly over it so you understand what that looks like.
Can I stop sharing, Prof?
You can.
Oh,
And then the
okay.
tibial tubercle osteotomy is something that can be added in the same procedure, or you just do it at the later stage. So that's the bony alignment procedures, but it doesn't change any of the soft tissue that's been either too tight or too loose for a long time. So medial structures tight, lateral medial structures loose, lateral structures are tight. And there's a procedure called 4-in-1. That means there's 4 things in one procedure, in one episode that one can do that addresses the soft tissues. And those 4-in-1 procedures are necessary to realign the patella once the bony realignment has been done. And you've mentioned all of them. It just makes it a little bit more structured to talk about it like that. So the 4-in-1 procedure is a lateral lengthening, and it's not a lateral release, it's a lateral lengthening. That means it's almost like a Z lengthening that one does on the lateral side of on the lateral retinaculum, so that you don't just cut it and then maybe the patella will pop medially or dislocate or sublux medially. So you can still lengthen and then still have some tissue there that you can kind of still keep the patella in its normal position, but still with some restraint to sublux medial. So that's lateral lengthening. That's one of the 4-in-1s. The second one is some form of medial stabilization. And usually that means some form of MPFL and medial patellatibial ligament reconstruction. So when you look at the MPFL, it's made of 3 main connections. The one is from the femur to the patella, the one is from the tibia to the patella, and the third one is from the meniscus to the patella. And depending on the flexion angle, those ligaments pull differently. The first 30 degrees, the connection to the femur is the most important one. But after the first 30 degrees, that femoral connection becomes loose. It needs to become loose, otherwise it over-constrains the patella. Now, the tibial connection tightens in flexion and loosens in extension. So that means the patella doesn't sublux laterally in flexion because of the connection it has to the tibia. And that's important to understand when you reconstruct these ligaments. So that the medial reconstruction is actually an MPFL and patellatibial ligament reconstruction. So that's the second part. The third part is that we need to somehow medialize the lateralized tibial tubercle. And in kids, you can't really do that just by cutting the bone and doing a tibial tubercle osteotomy because you damage the apophysis. So there's various ways to then medialize that attachment point. Let's say, Brad, do you know any way to medialize the patella in a child? So that's the third of the 4-in-1.
I was just, I mean, I think we do like a periosteal, like a subperiosteal elevation.
Yeah, fantastic. So that's the Grammont procedure. You just lift the periosteum off, the patella tendon is attached to the periosteum, but distally you don't cut the periosteum. So it becomes this long sleeve, and you can basically put the knee in 30 or 40 degrees of flexion, and patella sits in the groove, and now you know, okay, I'm gonna suture that periosteum back to the tibial periosteum, the periosteum of the tibial tubercle. You suture that into the tibia and keep it there, so that you basically medialize the lateralized tibial tubercle. So that's the Gramont procedure, and it's a very good option. Yeah. One more. They always talk about the Ruth. Excuse me.
I wanted to ask, how about if you do like an osteotomy, like distal to the tibial tubercle incision, and then you rotate, technically medialize the attachment?
Yeah, you can't do it distal, but it's actually something that people consider, and the pediatric surgeons are not too afraid of doing it, is to cut right through the tibia, the entire tibia, proximal to the tibial tubercle and proximal to the physis, and you can rotate. But a less risky procedure would be a Ruth Goldwave procedure, where you split the patella and you move the lateral piece under the remaining patella tendon, and so you split the patella tendon and you move the lateral limb of that split underneath the patella and then suture it on the medial side. Ruth Goldwave. Cool, guys. So that's number 3, and number 4 is a lengthening of the quadriceps tendon, because this patella has been sitting lateral and the quadriceps muscle has been very tight. And so once you bring the patella over, you have to lengthen it. That's a very complex problem, and it's not a lot of cases, and people usually don't really venture, you know, in the general orthopedic practice, they don't really venture out and do this. So it's something very subspecialist, and even the knee surgeons would say probably there's, you know, maybe people that have a very interest a big interest in pediatric kind of cases would do that. But here's just one of these cases. It's a derotational osteotomy. Can you see this?
Yeah.
Okay, good. Let me see if I can, because there's some sound on it. I'm going to turn the sound off. Okay. So this is marked. Here's the patella. It's sitting lateral, and, you know, there's just some kind of incision I'm planning out here. So I've now made that incision, and now I'm doing that lateralized, that lateral lengthening. So you kind of first take a superficial cut to the retinaculum, and you take it all the way down to the attachment point on the epicondyle. And then we have to release the entire fat pad. So this is pretty much that it goes all the way down to the tibia to be able to really release a lot of these structures that are tight and have been tight for a long time. So it goes all the way down to the fat pad that release. And then you can lengthen it. So this is now doing that osteotomy. Here we get going around the femur, distal, posteriorly and anteriorly, just to make sure we don't cut any neurovascular structures or the extensor mechanism. Now we just kind of place the plate, figure out where the plate needs to sit, and then we start with the first wire that marks the osteotomy. And then after that osteotomy, we mark out the second wire to make sure we're in the same plane. So that's basically the way to do the opening part of the osteotomy. Now we drill external fixation pins into the femur, so we know how far we need to derotate it. Here you can see we actually measure with a little wedge. We said we wanted to derotate it by 15 degrees, and that wedge kind of very crudely tells us that we can derotate it after those 2 pins are aligned in the frontal plane. Sorry, in the axial plane. Hopefully we've derotated. You saw Prof Laubscher there, so I'm not doing any mistake. Any big problems happen, so he's watching me very closely. Now we do a biplanar cut. So this is a coronal cut first. This is the first saw cut. And then, yeah, we're cutting that. Here is the axial cut. So that's the cut that allows me to open the wedge. That means to create varus. And now this is a third cut that we do to take out the wedge of that coronal saw cut, so that we can actually close the wedge by rotating it. If we don't do the saw cut, it's very difficult to rotate a coronal cut. So that saw cut is got a broad base on the lateral side, and then this, it goes to the its base, its acute angle is on the medial side. Now we can use this spreader to open up and create varus, and then with this X-fix I can then dial in the derotation. And this is pretty much what this derotation osteotomy looks like. And then we can actually drill a little screw in from the top to, once the rotation and the varus is acceptable, we can put a little screw through that coronal cut to be able to fix it. And we put the plate on, screw the plate down, and then you can see basically there's the opening of the derotation with some bone graft in there, and then the coronal that's kind of that screw that keeps everything in place. So you can see how thin this femur has become where we did the cuts, because obviously we reduced that width by the wedge that we cut out from to be able to derotate it. Okay, cool. So that's pretty much how the derotation is done. And maybe later on we can check on the tibiotubical and the MPFL reconstruction if you guys, if we still have time. Okay, Zama, well done. Any questions so far?
No, not for me, thanks.
Good. Okay, cool. So let's go on. Fidelis, did you prepare a case?
My case is just a patellar dislocation. I done the acute patellar dislocation, so I guess most of the stuff has been covered already.
Let's look at it. There's always more, Fidelis. Unless you didn't prepare anything. Okay, so good, I can see that. So Sama, can you hear me?
Prof, whose name did you just say? Mine.
Yeah,
Okay. Yeah.
Zama Lunga, Dr. Lunga. Your FC author is on the line. This is your case.
Okay. Oh, sorry.
So the question,
Okay.
like,
I'm presented. Yeah.
yeah, describe what you see, Zama.
Yes, I'm presented with a clinical picture of the left knee of a patient. One can appreciate abrasions over the anterior aspect of the patella with a laterally subluxed or dislocated, rather, patella, as apparent with the obvious convexity over the lateral aspect of the knee. Yeah, one can also appreciate some swelling and possible hemothrosis, but yeah, there's also an ecchymosis over the medial aspect of the knee. Yeah. That's about all I can see there.
Okay.
Yeah, it looks
fair
like
enough.
it's secondary to acute trauma. Yeah.
Yeah. What
Yeah.
would be your management of this lateral patellar dislocation?
Yeah. So I'm assuming this patient's come into casualty with this painful, deformed looking knee. So after taking a history and examining the patient, doing a neurovascular exam as well, I'll then reduce this, I'll reduce this under sedation, conscious sedation, and then place the patient in an above knee back slab or box slab rather. Is this the index
Yeah, it's the first time
sensation?
dislocation, yeah.
Yeah, and then I'll get imaging as well to make sure that it's reduced, as well as if there's any bony fractures or avulsions associated with this injury. Yeah, so when it comes to first timers, I think the X-ray will then help us with deciding who gets what, but we don't go jumping into surgical management as yet.
So
But yeah,
when
what
would you
does the
decide,
X-ray?
number one, would you do an MRI scan? Number two, when would you decide to offer this patient surgery? After an acute dislocation. So you reduced it now. And Zama, you didn't only look at the knee, right? You looked at the
Yeah, the
alignment, you
joint,
looked at
yeah,
other
sorry, yeah, all those risk
patient-specific
factors.
Exactly.
Yes.
So you've assessed all of this now, and then you'll tell the patient, look here, if we treat this conservatively, you'll have a XXX% of chance of redislocating. But
Yeah, so
unfortunately, you have certain risk factors, and these risk factors are XXX. Okay, so that's what I want to hear now. So what are you looking for now to determine whether this should be treated conservatively or operatively?
yeah, so as mentioned, index presentation of an acute lateral patellar dislocation. I think initially they would have been referred with X-rays. So in that, I want to exclude any loose bodies in the joints, in the patellofemoral joints, or in the in the knee joints essentially. And if there's any associated fractures with that, and then if there's any avulsions, as I mentioned previously as well, because then that'll guide me into thinking more essentially whether I am conservatively managing in a brace and then examining afterward. Let me just think about this. I think conservative management, if it's just a MPFL type injury, um, yeah, without any avulsion and loose body in the joint, I think we don't have to arthroscopically debride that or do some sort of repair. And then an MPFL repair, I think it's warranted if there's some sort of bony like involvement, like an avulsion, if I remember correctly, Prof, in these acute settings. Yeah, so it's either
So
conservative.
what you
Yeah.
want to say, you know, when the patient is sitting in front of you, and there's going to be a common, if you do any general trauma work, this is going to be a common problem. So even for a foot surgeon, Sama. So what you're gonna do
Yeah,
is you're
I
gonna
hear what you're
say
saying, Prof.
firstly,
I hear what you're saying. I don't know if I know the precise answer, but let me just give it my best. So
I, thi-
essentially,
I thought
to
you, I
my
thought you gave it your best. Did you not give it your
no,
best?
I gave
Oh,
it
okay. Let's try again. Okay. I'll give you another 2 minutes.
essentially we need to establish if this is stable or not over time, especially even with the conservatively managed patients. And with the bracing, we're essentially like aiming for scarring down of whatever fibers have been torn. And
What
then
position would you brace it in?
I think I'd brace it in full extension so that there's not much lateralizing of that patella. Yeah.
Actually,
I
you
think
know,
I'd
in full extension,
Is it worse?
The
me just
patella
think.
will, yeah, the patella will not be in the groove at all. And it will most
Yes, a
likely
30
be lateralized
degrees
because,
flexion.
okay. So in 30 degrees of flexion, hopefully this patella will sit more in the groove, right? Because between 0 and 30 degrees, the MPFL is the most important structure that will keep the patella medial. So if
Alright.
that MPFL is torn in 0 and 30 degrees, that MPFL is going to be too long and the patella is going to be lateral. So that's why a lot of people, us including, if this is an acute injury, we should actually brace this in 30 degrees. Obviously not too
Okay.
long, because otherwise this knee is going to get stiff in 30 degrees,
Yeah.
but for at least anything between 3 and 6 weeks. And it's done ideally throughout the week, and then once with the physiotherapist, they can do gentle range of motion exercises so it doesn't get stiff. But that's the main kind of concept of doing a patella, conservative patella management for acute injuries. Okay, so what you want to say is, I want to establish that there are no associated injuries here that need surgery, because you know you can treat the patella dislocation non-surgically, but if there is cartilage damage, meniscal injuries, or ACL injuries that are associated with this injury, then it might need to change. So that's why it's important to actually try to get an MRI scan, because that will allow you to exclude these injuries. Now, once these injuries are excluded, and you don't have an acute reason to do a surgery here, you can discuss with the patient and say to them, look here, without any risk factors, you have 50% chance of re-injuring and redislocating. If you are a strong person that's older, and this was an acute injury, someone bumped against your knee or you fell and this popped out, and there's no other injuries, you have a good chance, of 50-60% chance that this is not going to redislocate. But if you've got the risk factors, that rises. And there's actually scores. You don't have to remember what these scores are called, but there's scores you can take that take certain risk factors into consideration and give you an end score that will tell you, okay, now it's actually the risk is so high, it's like 80 or 90% now. And you can present it to the patient, and then you and the patient can make a decision on treating it now, doing rehab, and maybe treating it with the second or first redislocation, whatever they feel is important, is ideal for them. But in essence, as soon as you have redislocation, it starts to give problems with cartilage. So every time the patella dislocates out, you get condyle damage. And the condyle damage eventually leads to patellofemoral joint problems. So over time, the patella dislocations will not be good for the joint. And so the more risk factors the patient has, the more I would push for surgery. And the risk factors we can chat about later. But that's in essence how you want to treat an acute patella dislocation. So there's a soft tissue knee injury, a sport injury. The patient hears a pop, the knee swells up immediately. There's mainly three reasons for this. Summer, what are the three reasons? This is another very common problem in your practice. It's not exam. I mean, the exam is also important here, but this is real life. So what are the three things that can give you an acutely swollen knee? Literally, the injury happened and you look down, they look down on the knee, and it's like a big balloon.
Yeah. So like a periarticular fracture can be one of them to cause a hemarthrosis.
Yep.
Cruciate or some sort of ligamentous injury.
Yeah.
Can also do that. I'll just think of one more.
It's
Definitely
right in
not the
front of you.
meniscus.
Right in front of you.
Oh, dislocation.
Yep. Okay. So those are the three
Okay.
things, right? Those are the
Yeah.
three things that can cause you an acute swollen, painful knee. after injury. And then you know, with the patella dislocation, you know, basically know the philosophy of treating it. Okay, cool. Do we have one more? One more case? Who's
Yeah, I've got one, Prof.
okay? Hey, Mkhize, I forgot about you.
Okay,
You-
no, I'm not
you-
important.
You know, you were very important, but you weren't in the meeting today, so I completely I didn't have you on my radar at all. I'm
I was
sure
working,
you've
Prof.
you what?
I was
There was
working.
there was no
Working.
foot and ankle. There was no foot and ankle theater in the
The,
afternoon today.
yeah, the afternoon was Tom's list. So we were just wondering, probably Mkhize is, I don't know, probably like studying or something. I don't know. Preparing for this talk. Okay, let's make sure. Mkhize, give me your talk. Give me your. Let's give you. I would love to give you a case to Fidelis because he was chirping, you know. But who hasn't had? I think Brad hasn't had a case yet, eh? Let's give it to Brad.
Very cool.
Okay, so share your screen, Mkhize. Do you know how to do that?
I'm trying.
Yeah.
Give me.
You know, the problem is I've got a big a bar of chocolate here. Whenever I wait, I have to eat more chocolate, and it's terrible because I'm just consuming. I'm consuming calories here while I wait for you, Mkhize.
Sorry, Prof.
Okay. Okay, there's like this little green thing that you have to press. It's called share screen, and then you can.
Yeah, I'm on that. It's just I'm trying to sort out privacy settings.
Okay.
Just close all those other tabs we don't want to see, eh?
Yeah.
Prof, whilst we wait for Mkhize to know how to
Yeah.
use a laptop,
Yeah.
just regarding the MRI,
Yeah.
you know, I always it's like on call in casualty, and you get these cases with these acute like patella dislocations, etc.
Mm-hmm.
And whether I'm not going to get it done urgently, but now am I going to just brace and then bring them back to clinic and then hopefully they get an MRI within the year? Because realistically, you know, we're doing first world medicine in a place where we've got budget cuts, and even our theatre lists are getting cut. So I don't know how we're gonna do this. What would you guide us in terms of the MRI situation with these knee patients?
You see, that's what I mean about there's a foot surgeon talking, because I know you're doing MRI scans for the ankle dislocations. Am I right?
No.
Yeah. You see, that's the problem. That's a problem because
No.
you get to my rotation all the way at the end, and then it's like just down on the priority list.
No, we examine the patient and then we decide
Yeah.
what we're gonna do.
I think that's reasonable. You know, in the end, what we're talking about now is the gold standard, but it doesn't often translate in reality. So I think importantly, make sure in a patella dislocation that the patella is relocated and that the knee is, like I say, that if you brace the knee in 30 degrees and for 4 weeks, it's not going to get too stiff, and the patella is going to heal. It's going to heal well. You can, when you bring them back at 2 or 3 weeks, usually the injury has settled, and you can really establish whether there's joint line tenderness, which helps you to rule out a meniscal problem. And you can also assess the ACL better, which helps you to rule out if there's an ACL injury. In fact, ACL injuries are very rare. Most likely they'll have a cartilage damage. And the cartilage damage is usually on the lateral femoral condyle or on the medial patellar facet, because they dislocate out and then they flex the knee up. And when when you put the patella back, it's almost like that the same injury that you get when the shoulder dislocates, it's on relocation where the Bankart lesion and the Hill-Sachs lesion happen. It's the same in the knee. So yes, you won't make 100% of the injuries if you don't have an MRI scan. You won't diagnose them 100%, but I would say if you rule out a joint line tenderness already, you've ruled out a lot of other problems that they can have. But there's pretty much only an MRI scan that really shows you cartilage injuries. You can't do that with an X-ray. It's too difficult. Okay, cool. So, Cicelo?
Sorry, man, Prof. I've sent it to Fidelis. This is it now.
Okay.
My laptop's being weird. But anyway,
Yeah.
this is the case that I've got for whoever would like to take it on. Pretty
I think,
straightforward.
yeah, Brad. Why don't you go, Brad?
Okay, sure. So it's a 26-year-old male presents with episodic patellar dislocations, anterior knee pain, weakness and apprehension in extension, and pain-free loading and flexion. Okay, so it's a mature male, episodic patellar dislocations. Sounds a bit, yeah, it's a bit concerning that could be in the habitual sort of picture, but it'd be uncommon for that to be a male. It may have been an initial traumatic dislocation, and now we're talking about recurrent dislocations. The clinical picture there looks pretty normal. The patella is outlined, the tuberosity there being marked. On the lateral image that I can see on the top page there, it's a skeletally mature lateral picture of the knee joint. So the standout thing is the patella alta, which we can quantify a few different ways. I think the best method is the Cato-Duchamp ratio, which we use, and that can be measured the posterior part of the patella down to and then from that, the inferior facet down to the plateau. And a number greater than 1.3 is increased. And then just looking at the trochlea, I don't particularly see any spur there. I don't really see a crossing sign either. So based on that lateral, I think you've probably got a normal trochlea, although I could be wrong if I'm looking at these pictures coming up here. Can I see the second page?
No, that's it. That's the case essentially. It's
So
patella alta, as we said, and if you look on the lateral without measuring ratios, if your Blumenstein's line doesn't line up to the inferior pole of the patella, it's usually an indication of patella alta as well. And then, Fidelis, if you could scroll down, please. I just wanted to show like some axial cuts of the CT scan. The one on the left shows a normal patella sitting in the groove nicely, and then the images on the right show patella alta, and as you can see that it's been lateralized or subluxed laterally, and then the image on the bottom right shows with the quads contracted, and it shows that proximalizes it more, and it subluxes that patella even more so. And then can you scroll down again for Fidelis? And then just to show that there are, like you said, quite a few ways to quantify it, like the Caton-Duchamp, the Insel Salvati, and the Blackburn peel. Yeah.
Can I ask you, Brad, can you make that a little bit bigger, those measurements? So we're now looking at, we were talking about patella height measurement, right? So the first case, Brad, we spoke about how to assess patella trochlear dysplasia and a little bit of TTTG. And the second case, we spoke about that we need to look at the alignment and how to assess it and how to treat it. And this is now basically, how do we look at patella height and how can we treat patella height? So let's look at this, Brad, and just tell us when would you do what here? Sorry, firstly, which is the best measurement for you?
So the Caton de Champ, I've now learned that one recently. That's the better measurement because it's two bony landmarks that you're using. The Insel-Salvati ratio must be done with the knee at, I forget now if it's 15 or 30 degrees flexion to get that measurement. So the Caton de Champ is more accurate. So we prefer that one. And then they have similar ratios. So the Insel-Salvati 0.8 to 1.2 and the Caton de Champ just, I think it's 0.6 to 1.3. So just a slightly wider range. And above that 1.3 is regarded as, I suppose, abnormal or pathological. That wouldn't be my trigger to definitely address anything surgically. It would have to be in the setting of other problems. So for this example, obviously now the patellar instability. So recurrent patellar instability with a increased or patella alter, increased Caton de Champ ratio, and most likely having failed conservative therapy, that would then be an indication to address that problem, that mechanical problem surgically. But I think, yeah, majority of the time, a patella alter alone is definitely not addressed and firstly addressed with conservative management.
Okay, so sorry, I was just stuffing my face with this time an apple. So the main thing is Caton de Champ is the way to measure the height in patellar instability, because it relates the joint surface of the patella to a distance that is independent of flexion, which is between the end of the joint surface of the patella to the start of the joint surface of the tibia. So if you look at Blackburn and Peel, that line that it relates to is the horizontal line drawn through the joint line drawn through the tibia. It changes in flexion. So the further you flex the knee up, the longer this line gets, and this changes the relationship. In Salvati, it doesn't actually take a measurement of the joint line. It takes the measurement of the entire patella. And so if the patella nose, which is the distal part of the patella, that's not part of the joint. Some patients have a long patella nose, and it makes the patella very long. And it changes the relationship of that ratio in that it masks a patella alta, because you have this big patella, but actually the joint surface is a lot more proximal. And that's why all of these other measurements don't really relate as well, the true relationship, or they don't measure the true relationship as well as the Caton de Champ. All of these that you see here are indirect measurements. So that means it relates the patella to the tibia. There are also direct measurements that relate the patella to the femur. And those are, for example, what Cecilia was saying is you can kind of, there's relationships that are described to the Blumensatz's line, but a very nice way to describe that relationship, so the direct relationship to the femur, is an overlap of the joint surface of the patella to the joint surface of the trochlea or the femur. And that overlap should be more than 12%. So that's the patellar-trochlear index that was described by BDAT, and that's also something that we often use. So that you can only use on an MRI scan, but it gives you a direct relationship to the femur, not an indirect relationship to the tibia. Okay, cool. Let me maybe wrap it up with my presentation, where I'm going to give you just a basic anatomy and kind of the terminology and a little bit of an algorithm to treat these injuries that kind of gives you a nice framework to speak about these injuries when you're in an exam, but also to think about these injuries when you're in front of a patient. So maybe if you de-share or unshare your screen, Fidelis, then I can share my screen. No, I have to make sure I share it correctly. Otherwise, Keys is going to laugh at me. Okay. So, can you see this, Mkhize?
I can see it, Prof.
And did you also note that it just took me 3 seconds? Okay, good. Just making sure. Oh, but now problem is I can't click on now. Anyway, so it's a science, and art science means we can measure stuff, and art means we look at stuff and interpret that with experience. But it's difficult to quantify the instability, and it's often overlaid with pain. So pain and instability are often there together. And it's worth to really understand, does the patient have instability, or does the patient have pain, or both, and what's more important? And so it's a spectrum of a problem from normal tracking to mild tracking, traumatic dislocations, and then recurrent and even permanent dislocations. So it's really, the patients often are not like on one, but they actually move, sometimes even move through the spectrum itself. And this is what we spoke about. This is a dislocation that's described based on the direction. And this is something that's come out of a consensus statement from the Patellofemoral Instability Working Group in 2018. And this is something that you can always kind of, when someone asks you, how do you like put in your head, how do you frame or classify these injuries? It's either a medial dislocation or lateral dislocation. It happens either in flexion or in extension. And this really helps us to also guide treatment. But the instability in the first degrees of flexion is the most important and most common reason for instability. And we spoke about this its instability in kids. So a good way to look at it and speak about how to assess it is either you say, I'm going to look for soft tissue, bony procedures, and general alignment and laxity. And then you can look at the patient, the limb, the patella, the trochlea, and the motion. So when you look at how the patella moves, you can see the contact area initially at 0 degrees is not even in the trochlea. It's far out up there. And it only kind of starts to engage with the trochlea at 30 degrees. And so at 60 or even further, 120 degrees in deep flexion, the patella actually doesn't even contact the trochlea at all. In fact, it has only got 2 small little areas of contact points on the medial and lateral femoral condyle. And when you look at on the surface of the patella, you can see that in 30 degrees, its contact point is quite proximal. And then as it moves distal, as the patella moves into flexion, the contact points move more distal. That's important because oftentimes you have got some injuries to the cartilage, and you can actually move the patella distal or medial, and it will obviously influence also where these contact points are. For example, if you have a patella that's got a medial condyle injury, let's make it a lateral condyle, a lateral facet injury that's distal. And if you move that medial, the patella, if you move the patella medial, you're going to start engaging that lateral facet more. If you have a distal injury of the patella and you move the patella distal, you actually bring that contact point out of the zone, out of the contact zone quicker. So if you have a distal injury, if you have a proximal injury, for example, and you distalize the patella, you'll have a contact point and a contact stress on that proximal pole. That's a lot more. So by looking at the cartilage defects, you can actually consider how you move the trochlea, the tibiotubercle. So the tibiotubercle is not only moved for instability, but also to unload some of the injuries in the trochlea, in the patella. It's not a perpendicular femoral axis tracking of the patella, but it's a little oblique, and the lateral femoral condyle is a little bit higher. The trochlear is a little bit higher. That prevents subluxation of the patella. When you look at the MPFL, and this is now an anatomist, Smigelski from Eastern Europe, who looked at the anatomy of the MPFL from inside out, so not from outside in. The surgeons always look anatomy from outside in because that's how you cut down to the anatomy. But if you look at it from inside out, then you actually see a different structure to the one that's been described before. And it's actually almost like a ribbon-shaped structure that is attached to the tibia, like we said, to the femur, and then also to the patella, but also all the way up to the quadriceps tendon, and the VMO also inserts into it. So it's got a dynamic component. It's got a component that attaches to the quadriceps tendon, not just to the patella. And this is how Laprade looked at him. So a surgeon's anatomy looks different. It looks it's always described in bundles because that's what we know to reconstruct. And you can see he's got these pretty much these three main connections: one to the femur, one to the meniscus, and then one to the tibia. And these are the main. This is the main restraint to lateral subluxation. And if it turns out, actually, if you were to cut the MPFL, the MTFL, the medial tibial femoral ligament, has got a lot of, it accepts a lot of load. So the load to failure is almost as much as the MPFL, but obviously it acts at completely different flexion angles. And this is an important graph because it shows us that when you, so the MPFL, which is intact here, you can see that dot that's dark. In 0 to 30 degrees is where it has most force translation. And then in flexion, it slowly, it basically, it doesn't really become too tight. So even the sectioned ligament, and it's not the direction of the graph is very similar to the intact ligament, but initially the first 30 degrees of flexion is where it changes. You can see 0 to 15 degrees, the MPFL is tight. In the 90-degree angle, that MPFL is loose, and the lateral joint opens up even more. And that's important when we reconstruct the MPFL. Make sure that it doesn't get tighter in flexion. And these are basically the biomechanics. You can see there's some soft tissue, some bony, and some alignment that keeps the, some bony structure and some alignment that keeps the patella medial. And some of these are passive and others are active forces. So there's a lot of things that play on the patella and make the patella move around. And that's what we just discussed earlier. So we initially, and when we have the acute injury summer, so these are the key questions, you know, was it low or high energy? Was it very easy that this patella came out? Was it just you kind of turned and it just popped out? Or did someone in a rugby match hit you from medial and it just tackled you and popped the patella out lateral? How easy was it to reduce? And do you have a family history of this? And then it's very much the same as in the shoulder instability. You want to know, you know, when did this start? Is it bilateral, unilateral? How many episodes did you have? Is there pain involved? And what are your goals and expectations? Upper laxity, we spoke about that, very important, because most knee injuries that are ligamentous are somewhere, laxity is a major risk factor. So it's always something you start with. And then we looked at this axial alignment, and here you can kind of see what the problem is with a coronal malalignment or an axial malalignment. So rotational or valgus malalignment gives you a problem with the tracking of the patella. This is the way you assess rotational alignment: 3 tests: foot progression angle, the external internal rotation of the hip, and then the foot thigh angle these three things will allow you to kind of gauge what the where the rotational alignment is. But then you still have to figure out, okay, what is actually my limit to, okay, acceptable limit. So I would say if the one leg is got a high, or if you have a much higher femoral neck anteversion than expected, or if you have a lot of valgus and rotational malalignment, then you would say, okay, let's figure out exactly what this malalignment is. And that you can really only do with the CT scan, where you can superimpose the femoral neck anteversion onto the epicondylar axis. And that allows you to know exactly how much of internal rotation malalignment this femur has to be able to say, okay, well, I have to derotate it. So we aim for about 15 degrees of femoral neck anteversion. So anything that's more than 30, where you have to correct more than 15 degrees of malalignment, is something that you would consider treating surgically. And that's a very crude way to look at it. But I mean, that's pretty much, I think, what our limits are. The patella tap to make sure that there's no fusion, then pain on the medial femoral condyle. These are all very specific, or specifics for an assessment of the patella. And then the apprehension sign, similar to the shoulder, the apprehension sign, anything that's a grimace of the patient, pain for the patient, or quadriceps tensioning or contraction, when you try to move the patella lateral, is throughout range of motion, is called an apprehension sign. And that actually, an apprehension sign is something that kind of directs you towards this patient who's got symptomatic subjective instability. It doesn't necessarily mean that there's objective instability. It just means that this patient doesn't feel like the patella is sitting in the groove. And this is an objective way to figure out whether the patella goes lateral. So you can actually push it lateral in more than 50 degrees, 50% in quadrants. More than 50% of moving the patella lateral is pathologic. Now, the motion is another thing. So this is the J sign. You can see the J sign. On the left, there was a tibiotubercle osteotomy, and on the right, there wasn't. And you can see that the patella migrates lateral on the right. So we didn't medialize and distalize the patella on the right, and that's why you have the J sign. On the left, we did, and you can see the patella tracts medial. And you can see how the J sign looks with the trochlear spur. So there's almost like a jump in the J sign. It's not a smooth J sign, but there's a little clunk. And that's actually where the patella clicks over or jumps over that spur. And that's an indication, potentially an indication, to do a patella, a deepening procedure. You see, there you go. And then we can have mal-tracking after lateral release. So this is a problem with lateral release. Sometimes you have this, you can see this J sign actually goes medial. And then it becomes a little bit more tricky to sort out. And this is what a fixed lateral dislocation looks like. You can see the patella is fixed lateral. There's no extension or very little extension because the pull of the quadriceps muscle is not over the fulcrum of the knee. So it can't actually pull. It has a short distance, and it doesn't have biomechanic advantage. So this is something that you can't sort out with an MPFL. A lot of these tests have poor inter-observer reliability. So there are these tests that we just discussed now, but we just need to understand that these tests should be seen as a whole battery of tests and not just one single test that will tell you that this is dislocated or dislocation or a patella tendon, a patella that that subluxes. Now the signs. So these are all the degrees, and obviously, if you only look at signs, you're not going to be able to be a good examiner. So you have to take it always with a little bit of a clinical insight. We spoke about these measurements, and the patellar height measurement. This is the direct measurement of the beaded beaded and Albrecht or the patellar trochlear index that we spoke about. 12% of overlap is normal, and less than 5% is you should consider doing something about. And patellar tilt is something that people obviously could measure early on, and they've made this a big risk factor. More than 20%, 20 degrees of tilt is a risk factor to lateral dislocation. We spoke about the trochlea. We spoke about how to look at the X-rays. This is the dysplastic crossing sign. Here we've got a spur and a double contour as well. And then this is how a spur looks like when you open up the knee. So that spur here, you can see that spur translates pretty much into the X-ray, which you can see here. And we spoke about the classification. This is the Bristol classification. I think is the best to remember and something that you can always pull out very easy. Shallow, flat, and concave. So why do we do MRI scans? We spoke about that. MRI scan in an acute patellar dislocation, 70% of the MPFL is injured. And then we have the lateral femoral condyle and the medial patellar facet. You can see here, that's the medial patellar facet that's got a cartilage injury. The TTTG is the tibial tubercle to trochlear distance. How to measure it is it's a perpendicular line of the to the posterior condyle, and that perpendicular line is drawn through the tibial tubercle and through the trochlea, and the distance between the two is measured. That distance is depends on flexion, and so actually Cameron Anley was part of this. Yeah, Cameron Anley, American Journal of Sports Medicine, 2015. He's now a shoulder surgeon, but he came up, or he measured this TT-PCL distance, and that's not dependent on flexion. So it's a little bit more accurate because you never know exactly how much this knee is flexed in the MRI scan. And it's a different way to measure it, but it's also got relevance if you're unsure of the TTTG and the flexion of the MRI scan. We're not going to talk about that because we spoke about that. There's various ways to describe the trochlea in terms of depth, the lateral angle of the lateral trochlea, and also some of the asymmetry of the facets. If there's more than 40% of asymmetry in so one facet is less than 40% in the other, then there is some form of patellar dysplasia. And this is, I think, again, one of the things that make you sound very as if you have this concept in your head, as if you've got some structure. If you say, look, I'm going to look for the Lyon factors of instability. Lyon is an epicenter of knee surgery, and there's a guy called de Jour, and this de Jour guy has described the dysplasia, but he's also made some interesting he drew some interesting conclusions from various patient cohorts to say that there's these 4 factors. If you have those 4 factors, all of those 4 factors, then most commonly you'll have a massive problem with instability. But even 2 of them, the patients that you operated with patellar dislocation, even 2 factors, more than 50% of the patients, more than 50 patients of his cohort had at least 2 factors. And that is the Caton Duchamp of more than 1.2, the trochlear depth of less than 3, the TTTG of 20 or tilt. We spoke about the rotational alignment and how to measure this. And so let's just quickly speak about surgical indications. 1/3 is management is 1/3 of patients have got good outcomes, and the other 2/3 have got either pain or instability. And that's the reason why we need to look for these factors before you make a decision of treating a patient surgically, conservatively. And the main kind of term that needs to kind of come out is an a la carte. It needs to be managed a la carte, with a la carte surgery. A la carte actually means we're going to decide on what's pathologic, and we'll treat those kind of factors of pathology. This is a way to evaluate whether this patient will redislocate. We spoke about this score, the Barker score, and we don't have to know the name. You just have to know that there's a score which kind of keeps some of the risk factors and evaluates them, and then spits out a number. And if the patient's got a higher number, then the instability, the risk is very high. But in essence, it's similar to the shoulder. It's either weak atraumatic with risky anatomy, or the patient is strong. It was a traumatic injury with normal anatomy, and then they have got a lower redislocation rate, obviously. So if you kind of group these patients into those two different groups in your head, then already you've actually done the patient a huge favor. We spoke about this. This is acute dislocation, and these are some of the risk factors we looked at. And now for recurrent instability. So there's basically these risk factors that you can a la carte offer some surgery. Risk factors are, in a normal patient with no risk factors, but there's recurrent instability, you just do an MPFL reconstruction. In a patient with a lateralized tibiotubercle, and Brad mentioned, if it's more than 20, that's kind of a thumbsuck figure, or TTP set of more than 24, we do a tibiotubercle osteotomy that medializes the tibiotubercle, or a Fulkerson doesn't really medialize it, it anteromedializes it. But that's pretty much what we would do with the lateralized tibiotubercle, and we add an MPFL. So in essence, you can see there's MPFL everywhere. So it's not really a la carte. It's actually, we're going to do an MPFL reconstruction plus something more. Patella alta, more than 1.2. I think that's a very low number. I would say probably 1.3, even 1.3. Sometimes I wouldn't now necessarily jump into doing a distalizing osteotomy, but anything that's like 1.3, 1.4, you should really consider it. Distalizing tibiotubercle osteotomy to pull the patella down, make it engage in the trochlear earlier, and then an MPFL recon. Patella tilt, there's some value in doing a lateral release to not over-constrain the patella when you pull it medial with the MPFL, and then the trochleoplasty. And that's really, if you look at it, initially, most people were treated with an MPFL reconstruction and tibiotubercle osteotomy. And then only if it doesn't work, a trochleoplasty. But if in your hands a trochleoplasty works very well, then you can obviously add it to all of this tibiotubercle procedures. But I think the main value really is for a trochlea that's convex. In that convex trochlea, you'll be able to really be able to help the patella to track better if you deepen the patella, the trochlea groove. And that's pretty much it, guys. Well done. Let me just go back.